everyone, and welcome to our talk for today on investigating surgical site infections. I know there's a lot of you from around the globe, so just a short introduction about me. My name is Dr. Elethia Dean. I am a volunteer faculty with Orbis, probably for about 12 years plus. I'm a nurse. I have my PhD. I am also one of the editors for the ophthalmic nursing textbook. And I travel the globe helping to improve healthcare. I work in the US as a consultant, helping with surgical centers, operating rooms, in improving healthcare there also. And we're going to go ahead and start because I know we have a very short 1 hour and we have a lot to cover. So if there's anything else, I think you could probably Google, but that's me in a nutshell. So today we're talking about surgical site infections. All of us get into medicine to do that one major objective. First, do no harm. When we got in, that was part of our training that whatever we do, we never want to leave our patients in a worse condition than how we found them. Patients come to us because they want to improve their healthcare from where it is. So one of the things we're going to cover now is about when a surgical site infection occur, how do you make sure that that cause did not happen with you or your facility, whether it's in your OR, in your instrument room, pre-op, post-op, it didn't occur as a result of your patient entering your facility, and that you were still maintaining that objective to first do no harm. So as we start, we're going to go ahead and we're going to just have these fun little polling throughout the talk today. So first, we're going to ask you a question. When investigating a surgical site infection, analysis should be done only when an organism grows at the surgical site during the postoperative phase. So just use your device. If you're on a laptop or a computer, just use your mouse and click true. If you're on a mobile device, you can just touch true or false. If it's false, just false. If it's true, touch hit true. You can go ahead and click it now. When investigating surgical site infections, you should only analyze these things if only when an organism grows at the surgical site during the postoperative phase. We'll give you just a couple seconds. Okay. So 34% of you say true, and 66% say false. All right, we're gonna go on. Let's see what this talk is going to bring in here. All right, when you have an infection, the very first thing you need to do is to create a definition of what cases you're going to include as an infection. And so that 66% of you already knew that sometimes you may have either infective processes or inflammatory processes that mimic infections. And sometimes you have growth of organisms, sometimes you have no growth. So what are you going to study? What are you going to include in your definition of an infection? And we're going to go on why it's important to include both your no growths as well as the growth of organism, especially in the field of ophthalmology. Now, looking at the questions that have come through already, I can tell that there are people globally who work not only in ophthalmology, but in many other specialties in the hospital. A lot of us don't have that privilege of specializing only in one field. We might do cataract cases or ophthalmic cases, but we also do other cases. And so what the principles that we're doing today can be used in every single specialty. The same processes will be required whenever you have an infection, whether it's just in an eye or in a lid or an ophthalmic case, or whether you have a spine case or a GYN case or whatever it is, you can use these same principles. Then you need to determine, are you only going to include endophthalmitis cases, or you're going to include toxic anterior segment syndrome cases, or TASS, right? So in order to define what falls into an endophthalmitis case or what falls into a TASS case, I never assume that that everyone know the difference between TASS and endophthalmitis. So this is one of my favorite slides when it comes to how do we know what we're dealing with. Now, remember, in medicine, you can never say never and you can never say always, right? So there's always a little gray on either side of it where, if you have a large amount of bacteria or pathogen, you can have an endophthalmitis show up less than 3 days. Or if the patient has a really strong immune system, you may have TASS show up a little bit further past that 24 hours. But as a general rule, with a toxic anterior segment syndrome, it's going to show up 12 to 24 hours after surgery. Endophthalmitis cases usually show up 3 to 7 days after surgery. TASS is usually painless. Endophthalmitis is painful. Think about it as TASS is an inflammatory process. Endophthalmitis is usually a pathogen, right? So that pathogen is growing and it's painful. You're going to have hypopyon in both, where you have those cells at the bottom of the, when you look through the slit lamp. The TASS, toxic anterior segment, it's only limited to the anterior segment. You're not going to find it in the vitreous. Endophthalmitis, you can have it in anterior and posterior segments. TASS usually occurs in clusters, which means you're going to have a lot of patients, right? If you're going to have it, you're going to see patient after patient. Endophthalmitis occur individually. Saying that, I've seen cases where both of them occur in clusters. So, but usually endophthalmitis, you're not going to find, 10 cases in one day, hopefully. TASS usually gram stains negative. Endophthalmitis could be, the gram stain could be positive or negative. With TASS, though, this is very important. The outcome, both of them can cause loss of vision. But with TASS, it's very important that topical steroids are started every 1 to 2 hours. Endophthalmitis is treated by the retina surgeon with antibiotics and or steroid injections. And so with this, if you delay the treatment of TASS and send it to the retina surgeon, then you can end up with permanent vision loss. So it's very important early on to define, what are you dealing with? Are you dealing with TASS, or are you dealing with an endophthalmitis case? So once you have this definition in place, then you want to start your actual infection investigation. So there are certain primary components that are included in every infection investigation, no matter what the specialty. First, you're going to confirm you certainly have a problem, right? we have the presence of an infection or inflammatory process. Then you want to alert key partners about the investigation. You don't want the other physicians coming in not knowing that you're experiencing a problem, and then they have negative outcomes, right? Or they may choose to treat their patients prophylactically different if they know that there's a rash of infective processes coming out of this one operating room or out of this one hospital. Then you want to perform chart reviews. Why do I say chart reviews? Infection investigations are mostly retrospective. I would probably be good to say they're always retrospective. Hopefully, you're not one that is going to be planning to have an infection, right? So that's why you're performing chart reviews, looking at things that occurred in the past and what are the commonalities between those cases that had infections versus those cases that did not have infections. So therefore, with that comment, you know that you're not just going to include your infective cases, right? You want to look at maybe all cases that happen on the days when those infective patients had surgery. So you can say if they had the same, if they occurred in the same operating room, it might not have been the operating room environment, or if they had the same scrub tech or instrument tech or whatever it is, so that's why it's important to look at the chart reviews. And we talked about already establishing a preliminary case definition of what's going on. Are all the cases growing pathogens, or are some cases inflammatory processes, but it's mimicking an infective process? You also want to develop a methodology for case finding. How are you identifying those infective processes? Are you doing active surveillance where you're going to all surgeons who operated on those days, or all cases? How are you finding out whether or not a patient had an infection? So that you can either do active surveillance where you go to the physicians, or you do passive surveillance where you wait for people or the surgeons or the offices to tell you, hey, we had surgery, a few patients had surgery over there and they had an infection. So it's always better to do active surveillance, because the physicians or physician offices may or may not think it's relevant to come and tell you. Then you want to prepare an initial line list or an epidemic curve. In essence, this is just looking at your data. When are you having those infections? Is it every Tuesday you see a spike in infections, or when Dr. Smith or Jones, and in the States, Dr. Smith and Jones is just a general term, right? It's just a name we throw out there as just in general, who is it occurring only when one surgeon is operating? Then you want to observe and review any potential patient care activities that could have led to the infection. So for ophthalmology, look at how the staff is how they're applying eye drop medications. Are they touching the lashes and continuing on and not discarding the medication? And I know sometimes globally it's like, oh, these things cost so much, we can't throw away the bottle if it becomes contaminated. But you have to think, what is the cost of somebody losing an eye? Sometimes a $10 or $15 US bottle is worth it, because people deserve the same quality healthcare, even whether you're in a third world country or you're in New York City at the most expensive hospital. We all deserve the same quality healthcare. Then you want to look whether environmental sampling should be performed. Now, how do you determine that? Do you need to do environmental sampling? Sometimes that can become quite costly, right? Usually you want to look at the bug that's growing out of the eye. If you're having organisms that you frequently find on surfaces, then you might want to consider environmental sampling. If it's a bug that is not, or if it's something that is frequently, so for example, Serratia marcescens is frequently found under with artificial nails, right? And so you want to look at those implicated patient care activities and see, are the staff, is anyone around patient care, whether it's pre-op, intra-op, post-op, um, any patient, any employee, I'm sorry, taking care of a patient with nail polish, artificial nails, gel nails, any of that, then you might want to do testing of that. So you want to make sure that you're following that bug, right? Don't just make a general statement, oh, we need to do environmental sampling. You're going to end up spending unnecessary healthcare dollars because the bug is not found at the sites where you are testing. And then you want to implement initial control measures, right? So look at anything that, for example, the gel nails or artificial nails or nail polish, et cetera. If you see that, that's a change that you can make immediately and you don't have to wait until you get to the end of your investigation and analysis. So where are most of these sources of investigations coming from? Excuse me. There are two different sources that they could come from. A common source means that all cases have the same origin, which means it's the same person or the same vehicle identified as that means of transmission. For example, if you had a bunch of endophthalmitis cases, and when you looked at it, all those cases had instruments used from one autoclave, that would be a common source, right? Because every instrument came from that one autoclave. When you did an analysis of the autoclave, you found out it's not been reaching the temperature required for sterilization. That would be a common source. A propagated source is a continuing source, means infections are transmitted from person to person in such a way that you can't really identify transmission from a single source. Propagated sources occur over a longer period of time than a common source transmission. Now, the best propagated source of infection that I can think of to tell you is COVID-19, right? One person caught it. They were around, a family of 12. Every one of those 12, they went out into the world and each 12, contaminated 12 more, et cetera, et cetera, et cetera. Now, with a propagated source like COVID-19, you could go back to patient 0, but that doesn't mean that you are going to solve the problem, because now you have so many infected cases, right? So the treatment will be a little bit more difficult with a propagated source than it is with a common source. So now you know the basis. You have an outbreak. Now, based on a review of your initial cases and initial findings, the following information should be gathered and compared. This is where the rubber hits the road. This is how you find out. You're looking internally to find out whether or not you've done harm to the patients that have come into your facility. So first, we're going to look at some demographic data: name of the patient, medical record number, age, sex, diagnoses. No, why, right? Name and medical record number, we're just going to keep those so that we can track back when they've had surgery, etc. Age, remember, you have a higher chance of having infections in the very old or the very young. Male, female, you want to see whether there is a trend there. Diagnoses, you want to see whether, are you seeing these cases with cataract patients or glaucoma patients, etc. Surgeon, anesthesia provider, is there a commonality of who's in the room and who's doing the surgery or who's doing anesthesia? Is there an anesthesia provider doing general cases that's contaminating the field, during cataract cases? Date of surgery, you want to see when are these cases occurring? Vital signs, especially temperature. Did the patient already have an infection when they entered your facility and it wasn't caught, right? You don't want to claim things that aren't yours, that don't belong to you. When did the symptoms begin? And remember, we talked about TASS and endophthalmitis and the onset, right? Very different timelines and onset. So the date of onset of symptoms will start your mind to trigger whether it's a TASS or an endophthalmitis case, where you can start figuring out on root cause analysis. The other things that you need to look at are the surgical procedure. And these are things when I do an infection investigation, I just begin an Excel spreadsheet and start it, in the first column, and I end up going to the right. Every one of these things is a column. And on the first column, I put the patient identification. So in the case, so I can tell, to the right, what commonalities, I can look down on surgical procedures. Are there different procedures? Which operating room was used? Are they all in one operating room? And I've done investigations where it was the operating room. There was an issue in that one operating room. How long did the surgery last? Remember, longer surgeries have a higher opportunity of infection or infective processes occurring. Surgical personnel, who's working in that room? Anesthesia personnel, vascular access, whether you're using an indwelling catheter or you're starting a peripheral IV. Any other catheters that the patient, Foley catheters, et cetera. Did the patient have an ET tube in? Steroids, I remember that may decrease or the steroids might make that happy place for bugs to grow, right? And maybe antibiotics, have they been on antibiotics before? Were they prescribed antibiotics and didn't take the antibiotics prophylactically? IV medications, fluids, were they given blood? The last two, intracameral and intrathecal medications. Intracameral, any medication that goes in the eye; intrathecal, anything that goes in the spine, especially if it's a compounded medication. I always strongly recommend that you record in the medical record the lot numbers of those medications. Why? There's been over the years an increased incidence of infections, whether it's endophthalmitis or meningitis, from these compounded medications, if the pharmacies are not using appropriate sterile technique. And so you want to make sure if something's been recalled, or if there's been something out there where in the community, and this did happen a few years ago with one pharmacy, and it hit both ophthalmology and spine surgeries in a rash of infections. And a lot of patients died, and a lot from the intrathecal injections, and a lot of patients lost their eye with the intracameral application of these compounded meds. I'm not saying you cannot use compounded medications, but make sure you track that information so that if there's an issue, you don't have to claim that it happened in your center. This happened outside your center. You just used the medication that was already contaminated and you didn't know. Another group of information that you need, does the patient have renal failure, malignancy, diabetes, heart disease? Are they immunosuppressed, smoking, things like that? These are things that would have a more welcoming spot in the body, right, for infective process. Now, once you gather all of that data, you want to do root cause analysis. Now, remember, root cause analysis, what you're seeing is just the weed, what's on the surface. You've got to dig down. How did this happen? The word root in root cause analysis refers to underlying causes, not the one cause of the infection. Sometimes you may come down to, yes, it's the autoclave, right? But, how did that happen? Was the staff not trained? So there's a lot. So, you see in the middle that major root, but there's a lot of things that fed into that caused that main root to occur. So you've got to drill down to that. So root cause analysis is an approach for identifying underlying causes of why an incident occurred. So first, step one, what is the problem? You've got to define it, define your goals. Then, why did it happen? Analyze the cause of whatever led into this root cause, into this problem happening. Then, what needs to be done? What solution do you need to implement to prevent this from ever happening again in the future? So root cause analysis, has to do with this mapping, define, analyze, and then prevent. A lot of us may remember Deming, who's known as a father of quality. It goes into plan, do, check, act. That all falls under the same thing, right? Root cause analysis. But we're going to go into a little bit more detail because sometimes there's steps within those places that within the 3 steps there, and also the plan, do, check, act, that we miss in analyzing an infection. So first you want to say, what is the problem? What is a reported infection? Is it a bug? Is it an inflammatory process? How was the infection identified? How did you define that infection? Then we went through gathering all the data prior. Now you're going to gather data that affects patient care. Who worked with the patient from the time they enter your facility until they left? What instruments were used? What autoclave were they sterilized in? Who did the sterilization? What medications did the patient receive? What equipment was used? What phaco machine, etc.? What supplies were used during the case? Did you have a change in your normal process, a break in sterility? Did the doc have to change gloves, or the scrub tech have to change gloves? Was there a fly on this field? Not in your world, just in Elethia's happy world, right? You want to look at those things. Now, one of the things that I always did when I ran the surgery center, the operating room, is I always had what I think it was called an aseptic technique indicator, right? So any additional opened peel pouches, we always wrote those down. Any torn glove that had to be replaced, anything out of the norm, we would write it down. Now, if those cases never had, and it was the aseptic technique indicator sheet, if it didn't have anything on it, we would just shred it. We would keep the ones where something out of the norm occurred. So therefore, when I had an infection, I rejected, but if an infection ever came up, it was easy to go back to see, oh, nothing happened that day or nothing happened during that case. That was out of a normal process. That those documents were not kept in the medical record. We just kept those as part of our quality control in the operating room. When did the procedure occur? And then you want to look at similar cases, those with infections as well as those without infections. You want to identify, is there a cause that you've identified? Was it the nails of the employees? Was it the autoclave? Was it education of your staff? Do you need to change policy? Do you need to change processes? Do you need to implement education, etc.? You want to document what will be done. And then you want to confirm that whatever changes you've implemented resolve the issue. You want to go back to the same process that you used to identify the problem. Whatever method was good enough to identify the problem in the first place should be good enough to identify whether your problem resolved. So let's say you went and let's say you did active surveillance, and every month you ask the surgeons, have you had any infections of patients who've had surgery in this facility over the past quarter, right? And let's say that showed that you did have an infection or a group of infections, and that's what causes analysis. When you're going back to do a follow-up, you've got to use the same technique and go back to the surgeons who've had surgeries or performed surgeries in your facility. So let's say you change your mind. Oh no, this time I'm going to call the patients and say, hey, did you have an infection after surgery here? You know that by asking the physicians, that was good enough to identify whether or not you had a problem. What you don't know is whether or not asking the patient would tell you whether or not you had an infection. Because the patient may have a red eye and say, oh, yes, I had an infection. But, commonly, after surgery, they may or may not have a red eye for a short period of time post-operatively, right? So you want to make sure whatever you use to identify, use the same process to identify whether or not the change that you implemented was good enough to solve your problem. If your problem, after you implement the change, if your problem was not resolved, there was either an error in the data collection or analysis. Either you looked at it and you thought the problem came from the autoclave when the problem was coming from the nails of the staff, or vice versa, or whatever, or you changed something else and you analyzed it incorrectly before. And so you have to go back to the drawing board, start at the beginning and see what you've missed. Sometimes it's good to get outside eyes in. Sometimes when we're in it, we see what should be there and not what's really there. And I know, sometimes even when I'm typing or writing up a report, I see the words that I want to say, not necessarily the words that are there. And so I always have somebody, look at, my reports to say, hey, check this for me and see, I have my assistant will check it and say, oh, no, I checked, there was a typo here or there. So it's the same thing when we're operating, and it's our home world, right? We see what should be there. We don't always see the obvious, right? So can't tell you how many times I've gone into a facility and I'm like, why is that there? And as soon as I walk in, I see it because it's not my home base. And so, if you're having issues and you can't solve it, make a friend with another OR manager, whether from another facility, et cetera, and help each other, and you can go and look through it and see whether or not it's something obvious that is causing the infection. Next, you have the documentation of an infection investigation. And a lot of people have problems with this. We look at it, um, but we don't document. I recently did an infection investigation, and I said, show me your documentation. And they're like, well, here are the charts we looked at. I said, yes, but how did you document it? And so sometimes, even like just with that Excel spreadsheet, the problem will just pop out. And when I did the Excel spreadsheet, I started there. And when I did it, I just pushed my chair back and looked, and I said, now I want you to look at the spreadsheet and you tell me where the problem, and they were able to identify it. So the documentation is very helpful in identifying the infection, investigating it, as well as coming up with solutions on what needs to be done. Now, the documentation should follow the same process as a quality assessment performance improvement study. And you're going to see the next few slides where I'm going to use the acronym QAPI. When I say QAPI, it's a quality assessment performance improvement. So you're assessing the quality of what you're providing in your facility, and you're implementing things to improve the performance of whatever is going on in your facility. So, the purpose of the infection investigation should be to improve the quality of healthcare that you are providing in your facility. All right. Now, what we're going to go through is the same as what we discussed before under the root cause analysis, those 3 steps, as well as the PDCA, the Plan, Do, Check, Act. It's the same thing, except this drills each one of those steps down so that you're not going to miss any element that's required in your analysis, right? So the first step is purpose. Why are you doing this analysis of the infection? So this is a statement of your purpose. So you want to state the problem. You want to say why this is important to address this problem. So, for example, it is the goal of this facility to provide safe, quality patient care to all patients who have surgical procedures here in our facility or whatever. And then you want to go through, and define your goal, your mission of your facility. So why are you going to study that? The next step is very important. What is your goal that you're trying to reach? And this should be set by your board, whether it's your governing board for the hospital, your surgical board, over your OR, whatever board or quality meeting that you have. This is the goal that you're trying to reach. What level of performance? It's important to note that depending on what you're studying, you may never reach 0 or 100%, right? So if 3 of us are in this room together and I'm doing a quality study on patient satisfaction, right? And 3 patients, and I say to the patient, what do you feel about the temperature? Is it too hot, too cold, or just right? Because it's so subjective, you're never going to get 0 or 100%. You're never going to find that happy temperature where everybody says it's just right, right? So on subjective issue, you want to make sure that you never say 0 or 100%. When it comes to infective processes, you want to make sure you use benchmarks. And benchmarks should be relevant to your specialty or to your facility. So if you only do ophthalmology, then what are the benchmarks for ophthalmic cases for endophthalmitis? Or what is the benchmark for toxic anterior segment syndrome? And you can Google that. I think that thing changes. It'll change every year, but it's low, definitely low, 0.0 So it's like it's either 0.2 or 0.02. So you want to just keep up with that online. Check with the Academy of Ophthalmology, check maybe, I'm not sure if Orbis has that information, but I know if you Google online, usually you can find that information from reputable sources, you know, um, not just, Wikipedia. You want to make sure that or People Magazine, you want to make sure that you have some kind of scholarly document of what level or what goal you're trying to reach. Then you want to write a description of your data that will be collected. So this is not where you're collecting the data. This is where you plan to go. So what data do you need to verify whether you have a problem? What is the frequency and severity of the problem? Where is the source of the problem? And how are you going to collect the data? So you can say active surveillance will be done by all surgeons who operated in the facility for the past month or 3 months or whatever. Retrospective chart reviews will be done of all patients who had surgery on the dates where surgical site infections were reported, etc. So this is just where you're talking about your plan. Step 4, you're going to show actual evidence of your data collection. So this is where you would have your Excel spreadsheet, or it's just data. This is not where you analyze it. Step 4, you're just putting the data there. Step 5 is where you analyze it. You're looking now at all the data that you collected, and you're saying, where do we have a problem? What is the problem? What is the frequency, severity? Where is this problem coming from? This is where you analyze it to see if you can come to a decision on what changes you need to make in order to stop these infections from occurring. Step 6, you're going to go back then and you're going to compare it. I'm sorry. You're going to compare step 2. That percentage, that threshold that you set. Did you meet your threshold? Maybe, maybe not. So you want to go back and look at your threshold. Usually, if you're doing this, you haven't met your threshold. You have a problem. And so where do you lie? So we're going to go ahead and say you didn't meet it so that I can go and implement a corrective action. So let's just stick to the serratia marcescens, and staff were wearing artificial nails in the operating room. So what corrective action are we going to do? We are going to educate staff on the importance of not wearing artificial nails. We are going to do audits, and staff providing patient care will not have artificial nails or etc. And you can do that one, or you could even do cultures. It's probably not necessary if you're going to already remove the artificial nails, but that is another option. If you have the resource to culture staff, then you can say, oh, serratia grew under, this staff member's nails and no other staff member. Then you can drill down to that individual. Then once you do that, you want to remeasure. You're going to go back, you implement the corrective action, and then you're going to say maybe 3 months or 1 month, or 1 month later, you're going to go back and analyze. So when you go back and analyze, you've got to go back and do the exact same thing. Remember, we talked about that in order to determine whether your corrective action corrected the problem. So at whatever time period, 1 month later, 2 months, 3 months, 6 months, a year, whatever it is, if it's an infection, you don't want to wait that long, though. You want to go back and say, look at your data collection again, analyze your data again, and go and compare it to your performance threshold again. And you're going to keep going over and over between step 7 and step 8, implementing a corrective action and remeasure. You're going to keep doing that until you achieve the performance threshold that was identified by your board in step 2. So, and that's what step 9 says. If the first corrective action didn't solve the problem, then you're just going to continue going back and over until you achieve the goal. And finally, you want to communicate your findings to your board throughout the organizations. So once you communicate the findings, we did have a problem, we've identified the problem, we've implemented the corrective action, and now we've resolved it. And I like this, and that's why we lift on 3, because we all have to be on the same page in order to end up with great surgical outcomes for our patients where we do no harm. All right, these are my references that we used in creating these slides, but we're going to just take just a couple minutes here, and I want to just see how much you've learned and how well you're going to be able to do these infection investigations, right? So this is where the rubber hits the road. And if you have questions that have come up throughout the talk, go ahead and type them into the Q&A. And at the end of this, I'll go ahead and we will review those questions and answer them. So true story. 3 patients. Patient number 1 showed up in the emergency room approximately 3 days after an intravitreal injection with a painful red eye. Patient number 2 came to the ER, the emergency room, about 2 days after an intravitreal injection with a painful red eye. Patient number 3 came to the ER with approximately 4 days after an intravitreal injection with a painful red eye. All 3 of those patients had intravitreal injections. All 3 of them came to the ER with a painful red eye, whether it's 2 days, 3 days, or 4 days post-op. So with the above scenario, here's our second question. With the above scenario, painful red eye with patients 2 days, 3 days, and 4 days after intravitreal injections, there is a concern for what? Toxic anterior segment syndrome, or TASS, endophthalmitis, all of the above, which means both of those, or none of the above. It's something else. What would your choice be? I'll give you just a couple more seconds. Just go ahead and click. All right. All right, great. Well, 57% of you got it. That's wonderful. Why? So remember, intravitreal injection goes into the back of the eye, right? Toxic anterior segment syndrome is in the front of the eye. So therefore, it's intravitreal injection, back of the eye. You're not going to find TASS in the back of the eye, right? That was a kind of hint. But second, remember, TASS is painless, endophthalmitis is painful because the buds are growing. Remember, we talked about that. So endophthalmitis is what it was. It was B because it was a painful red eye. And remember, TASS shows up 12 to 24 hours after surgery. Endophthalmitis, 3 to 7 days after surgery. But remember, I talked about, though it can gray. TASS could show up a little bit later. Endophthalmitis could show up a little bit earlier or later. So, there we go. So the answer was B. Wonderful. That's good. That's good. We're all getting it together. All right. Now, the next. So this is, remember, we talked about this, and I put this slide in here just so you remember. TASS is painless, endophthalmitis painful, and all of that. Okay, so Next question. 5 patients were seen postoperatively on day 2 with hypopian and painless decreased vision. Cultures were obtained from each patient, which showed no growth. Okay. Cultures were obtained from the autoclaves. 3 autoclaves were used to sterilize the instruments. And the autoclave 1 grew a gram-negative bacilli. Autoclave 2 grew gram-negative bacilli. And autoclave 3 grew gram-negative bacilli. Okay. Now, question 3. With this scenario above, you have 5 patients with no growth from cultures of the surgical eye. All of them had hypopian. All of them had painless decreased vision. And cultures of all 3 autoclaves showed gram-negative bacilli. The following should be suspected: TASS, endophthalmitis, all of the above, or none of the above. Give you a couple seconds. Yes. Okay, so let's start at the bottom. It wouldn't be none of the above, right? Because you have a problem and it's in the eye. And so most of it should be either a toxic anterior segment or an endophthalmitis. I can see where you say endophthalmitis, but this one grew nothing. The answer was A, toxic anterior segment syndrome, because, and here's the reason why. We didn't delve because this was not a TASS endophthalmitis course, but usually TASS is caused by the breakdown of bacteria in the autoclave. So this bacilli, when it breaks down in the autoclave, the byproduct, those endotoxin, the byproduct of the breakdown of the pathogen ends up in the eye, causing an inflammatory process. But I could see where you would say endophthalmitis, but hopefully once you do your investigation further, you would come down to see that at the point of the patient, there was no growth, which showed that there was inflammatory and not infective process going through. Yeah, good job. All right, let's go. Now we're going to go back and see if we've learned anything when investigating surgical site infections. Analysis should be done only when organisms grow at the surgical site during the postoperative phase. Now, when investigating surgical site infection, you should only analyze it if there is a bug growing or a pathogen. If there's a bug growing at the surgical site, true or false? All right. Yes, great, 80%. We've improved knowledge from 66% to 80%. That's beautiful. That is correct. The answer is false. So you need to investigate whether or not there is growth, because toxic anterior segment syndrome can lead to loss of vision, just like endophthalmitis can. Now, as you go through your processes and as you continue to first do no harm, bad things happen to good people all the time. And Orbis and through CyberSite has all types of resources available to you. If you can't figure it out, reach out to your Orbis staff, reach out through CyberSite or through Orbis and ask for help. Do not suffer silently. And if all else fails, I do have a contact information there if you ever need help, whether it's education for your staff or whether it's an infection investigation. We all deserve the best quality of healthcare, whether you're in a third world country, first world country, doesn't matter. We all deserve the same quality, and Orbis is here to provide and help everyone globally achieve that objective. Session, Dr. Dean. Thank you, Dr. Dean and Orbis. Oh, is QAPI in the US the same as audit in the UK? Yes, it is. It's the same. Audits, you would do audits is one part of QAPI in the US. Think about it as a pulse oximeter, right? You keep your finger on the pulse of what's going on. Let's say the patient is having surgery and anesthesia comes in and gives Versed or fentanyl medication to sedate the patient. And so the patient, then the oxygen level drops, right? The next thing you're going to do is put O2 on by mask or nasal cannula. And so you put the mask, you put oxygen on and the O2 saturation increase. It's the same thing as QAPI. So that's how you identify your infections. You want to maintain how many infections. If it falls below your threshold, you want to do a study. Patient satisfaction. So that's like your quality indicators, your audits, right? And then your study, your then will be when you have a problem, what will you do to identify the cause of the problem to improve it and bring it right back up into threshold. And thank you all for attending today and looking forward to more seminars and webinars in the future with you, whether online or in person, we will make it happen. Thank you.